Good evening to you all. As I promised that I will be giving the video of the UPSC paper 1, and I have already uploaded the paper 2, and subsequently for the next days I will be giving again paper 1, paper 2 simultaneously with the NEET PG and super specialty also with the subject which I teach. Now as the exam is coming nearby, so I will be discussing, I will be keeping the brief, the explanation, and I will be only focusing because I have just studied and I have analyzed which questions are coming frequently, so that it would be easy for you, those who are appearing in the exam in the UPSC subsequent year, this year or subsequent year. So I will be today, I will be now I will be discussing because paper 2 already I have discussed. So paper 1 I will be discussing with you. So UPSC paper 1. So let me start from the very first question, and the very first question is a easy question. Let me first, as a rule, I will tell you the question. You think for a while and then you plan your answer and then see if it is tally, if it tallies or not. Now question goes through like this. It is, I think, the question of cardiology medicine. A 60-year-old smoker, it presents with the retrosternal chest pain and diaphoresis. Now the ECG shows ST elevation in V2 and V4 leads, that is V4 leads is chest lead, for which the primary PTCA and stent placement has been done. Which of the following drugs is not to be advised to the first 48 hours of intervention? Now the option I am providing to you, abeximab, aspirin, enalapril and dexamethasone. So I think you have understood the question, and you think for a while, for 5 to 10 seconds I am giving you, and then I will be giving you the answer. And let me repeat the question once again if you have not heard. A 60-year-old chronic smoker presents with retrosternal chest pain and diaphoresis, and the ECG shows ST elevation in V2 to V4 leads, in which the primary PTC and stent placement has been done, and which of the following drugs is not advised for the first 48 hours? That is abeximab, aspirin, enalapril and dexamethasone. Now I think you have thought for the answer. So here the patient presents with the chest pain, and in the V2 and V4 leads there is a ST segment elevation. So if we consider in ACS, acute coronary syndrome, STEMI or NSTEMI, angina, aspirin, beta blocker and ACE inhibitor is given in any case. Okay, so abeximab is given in conjunction of the PCI stenting if the PCI is advised, and here already the PTCA and stent placement has been done, so abeximab can be given. And only the diagnosis of exclusion in this case, in the 4 options, abeximab, aspirin, enalapril and dexamethasone. Dexamethasone is not to be given because dexamethasone is a fast-acting steroid, and it has got no such role presently. Later maybe we can give or we cannot give, but as per the question, dexamethasone will be the answer because it is not given. Now I am coming to the second question. Now the question goes like this. The following drugs for the treatment of peptic ulcer disease after gastric acid pH, except, now the question is given, actually the question is given, but the question has to be given like this: the following drugs for the treatment of peptic ulcer disease after gastric acid pH except, that means which drugs, I'm giving you the option, that is ranitidine, sucralfate, rabeprazole and uh, pyrpentazine. Which of the following drugs is not given as a treatment of peptic ulcer disease? So you think for a while and I'm giving you the answer. Now, I think you have gone through the answer, you have gone through the question. The following drugs for the treatment of peptic ulcer disease after gastric acid pH, except, that means which drug is not given. So here the options are ranitidine, as I told you, sucralfate, rabeprazole and pyrpazine. So here the drug which is not to be given, or which is avoided, is sucralfate is actually sucralfate. The explanation for the sucralfate is actually, we all know that it polymerizes the pH of less than 4 and becomes a gel-like substance which strongly adheres to the ulcer base, and it is a physical barrier penetrating the acid enzyme and bile to come in contact with the ulcer base. And other drugs given in the choice, like the ranitidine, which is H2 blocker, and rabeprazole, which is a proton pump inhibitor, or pyrpenzine, which is a M1 or muscarinic blocker, can be given as a acid suppression. So gastric acid secretion inhibitor is H2-histamine, as we all know, cimetidine, ranitidine, we all know, roxetine, lamitidine, etc. And anticholinergic also we can give, and PPI also, various PPI are there, that is omeprazole, esomeprazole, protoprazole, lansoprazole, aveprazole. Okay, and now eloprazole has also come into the in as a new pharmacopoeia, so we can give. And apart from that, prostaglandin analog as a misoprostol can also be given, but here the answer will be sucralfate, because sucralfate actually for the gastric acid pH peptic ulcer disease we actually generally avoid to give. Okay, now the again a easy question which I am giving to you. Which one of the following CNS tumor commonly spreads to the meninges? Now you please hear the answer and then option, and then you will tell the I will give you the answer with the explanation. Which of the following CNS tumor commonly spreads to the meninges? That is astrocytoma, option A, medulloblastoma, option B, C, meningioma, option C, and D is the glioblastoma. Now you think for 5 to 10 seconds, because it's a very easy question, and I will give you only 5 to 10 seconds, and then I will give you the answer. So which of the following CNS tumor commonly spreads to the meninges? So astrocytoma does not spread, as we all know. Medulloblastoma also, and meningioma also does not spread. Only the tumors which spreads to the meninges is glioblastoma, and the neoplasm metastasis most commonly to the leptomeninges are melanoma, CA breast, lung, lymphoma, and leukemia. Okay, you remember, because these already spreads to the leptomeninges. So these are the some of the tumor, and apart from that, meningioma actually it originates from the dura mater and arconate matter. As we all know, it compresses the nearby structure and may lead to the calcification and bone erosion. So the option left with us is glioblastoma. So glioblastoma is always spreads to the meninges. Okay. Now coming to the next question. Now I am discussing only those questions which are already always used to come and always do come in one way or other, and it is the most frequent to be asked in the exam. Now this is also a very good question. It came, I think, in 2 to 3, 4 years it came. Lastly, it was last it was asked in, I think, 2004, 2003, 2002. Even in 97, 96 also it was asked this question. Now I am repeating this question. Repeating means I am telling the question. Sorry. Which of the following is not a feature of PV? Okay, myeloproliferative disorder. It is polycythemia vera. And which of the following is not a feature of polycythemia vera? Now let me give the option to you, and you think for 5 to 10 seconds, and then I will be giving you the answer with explanation. Now option A is elevated red cell mass, B is normal arterial oxygen saturation, C is splenomegaly, and D is elevated plasma erythropoietin levels. Okay, so I am telling you the question once again. You pause and you think for a while, and then I will be giving which one of the following is not a feature of PV, that is elevated red cell mass. Option A, option B, normal arterial oxygen saturation, option C is splenomegaly, and option B is elevated plasma erythropoietin levels. Now I think you have gone through the answer. You have made up your mind for answer. So which one of the following is not a feature? That means which of the following option which I have given is a wrong statement, wrong option. Elevated red cell mass, normal arterial oxygen saturation, and splenomegaly, and elevated plasma erythropoietin level. So in the PV, that is myeloproliferative, it is a one kind of myeloproliferative disorder, and in the case of the criteria which fulfills the diagnosis of the PV are red cell mass is always elevated, so option A is correct. Normal arterial oxygen saturation, so it is also correct. Splenomegaly is always seen, which you can clinically you can also diagnose, and if you find the laboratory values, the vitamin B2, I think vitamin B12 and B2 binding capacity is increased. Here the plasma erythropoietin level is always less. Okay, plasma erythropoietin levels never rises in polycythemia vera. It rises to other CNS renal tumors like in renal cell carcinoma or in other type of tumor. But in the case of the polycythemia vera, it does not rise. So this is the answer, and this is the wrong answer. This is the option actually. Elevated plasma erythropoietin level is the correct answer. Now, this question is also repeated always because I have seen analyzed, that is INH toxicity may cause. Now, I am repeating the question. INH is a ATT, anti-tuberculosis drug. So INH toxicity may cause the following except. Now, the option which I am telling is which of the following it does not cause INH, the side effect of INH. That is, option A is psychosis, option B is nephropathy, C is hepatitis, and D is peripheral neuropathy. Yeah, I think this is a very, 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 very easy question, and the moreover, the most important thing is this question has been repeated many times in the UPSC exam. So. Uh, Now, INH toxicity may cause the following except psychosis, option B nephropathy, C is hepatitis, and D is peripheral neuropathy. Now, as we know, actually, every one of you knows that INH causes peripheral neuropathy, it always causes. Hepatitis is always it causes because hepatitis is one of the side effect of INH, and psychosis also it sometimes it causes, and psychiatric symptom is being seen in INH, but nephropathy is seldom seen in INH. In other ATT drug like streptomycin, nephropathy is been seen, but in INH we do not encounter any type of nephropathy. So INH, so the nephropathy will be the answer here. Now, I think this is a question of medicine only, gastroenterology. Now, listen the question carefully, and then you think for the. I am giving you the option, and you think. This question is also repeated many times. Very high serum transminase, that is ALT by AST, ALT by AST, ALT actually and by AST more than 1000. International units per liter are seen in the following condition except. Now, except means you have to tell the wrong answer, which answer is not the option, not actually occurs. Now, the option is viral hepatitis, ischemic liver injury, toxic induced liver injury, and ALD, that is alcoholic liver disease. So you think for I am not giving you much time because it is a very easy question, and I am giving you only 5 to 10 seconds. Now, I think you have come up with the answer. Very high serum transaminase, more than this is ALT by AST more than 1000 is actually seen in all, that is viral hepatitis, it is seen very high. Ischemic liver injury is also seen. Toxin induced liver injury is also seen, but seldom alcoholic liver injury it is not so seen, because striking elevation, that is aminotransferase more than 1000, occurs almost exclusively disorder associated with extensive hepatocellular injury, such as just I told you, viral hepatitis and ischemic liver injury like acute heart failure or prolonged hypotension. And toxin or induced liver injury. Toxin induced, that means drug induced, like most of the drugs which cause liver injury. And in the case of alcoholic hepatitis, and in contrast to other cause of and to other causes of fatty liver, the AST and ALT are usually elevated 2 to 7 fold. Always remember that. And they are rarely more than 400 international units, and the AST ALT ratio is more than 1. Okay, so this is one of the striking feature. Alcoholic liver disease is never more than 1000, but still the liver injury is serious here. Now, this is also an important question. I think it is in dermatology, and this question has been repeated. It came in 1987. It is a very old. Then it came again, appeared in 2004, 2006, 2013 also, even in 2017. Now the question goes like this: 8-year-old child presents with the itching on the scalp. You listen the question carefully and then you think for the answer. A 8-year-old child presents with itching on the scalp with the loss of hair. A characteristic black dot. Okay, a characteristic black dot appearance is seen, and which of the following is the most likely cause? Option A, alopecia areata. B is pediculosis capitis. C is tinea capitis, and D is traumatic alopecia. It's a very easy question. Just you think for the answer, and then I will be telling you. Now I think you have thought for the answer, and always remember, when a 8-year-old child with the present with the itching in the scalp, with the loss of hair, patchy loss of the hair, and with the characteristic black dot appears, because black dot is very characteristic of tinea capitis. Okay, alopecia areata does not presents with a black dot, neither pediculosis capitis, because pediculosis capitis is a parasitic infection, and traumatic alopecia does not cause any black dot or something like that. Tinea capitis is more specific and it has a black dot appearance. It appears very characteristic feature. So Tinea capitis will be the answer. Now this is the question of this question is also repeated. I think it is repeated in 1991. So it is a very old question and it has been repeated again in 2008 also. ECT, that is you listen the question first. ECT, that is electroconvulsive therapy, is currently advocated as a line of treatment in the following condition except. Except means that you already know need not to tell that in which of the following option ECT is not advised. The option is catatonic schizophrenia, B is severe depression with psychosis, C is manic depressive disorder, and D is OCD, obsessive compulsive disorder. So you think for the option, which option would be correct, and then I will be coming you with the answer. Now I think I have to tell you the correct answer. ECT is currently advocated as a line of treatment in the following disorder except. Now in catatonic schizophrenia, severe depression with psychosis, or in the case of the MDP, that is manic depressive psychosis or disorder, the ECT is advocated. Okay, the ECT is done, because in the case of the resistant catatonic schizophrenia, though in the DSM currently in the DSM 5 we are we have not we have already not categorized as a different types of like catatonic, hepaprinic, etc. So but as the question is coming, so we have to exclude the wrong option. So catatonic schizophrenia ECT is advised, and in the case of severe depression also with psychosis, ECT is advised. In manic depressive also psychosis advised. But OCD we don't usually advise ECT, because in the OCD generally atypical antipsychotic, antidepressant like chlorpheniramine usually it has a good prognosis, and it usually is cured. And just for the information, we should remember the contraindication of ICT. In severe MI we don't give, and the case of the severe pulmonary disease, cerebral severe hypertension, etc., we don't give. And the rest of the option which I have told you just now, we give for the, we actually advise for the ECT. So these are the questions which I am discussing. It is actually these questions are being repeated. So I am not discussing the question of part of paper 1, which has been coming as a new. The question which has been repeated, because it is very likely that the question will be come again in the subsequent exam where you will appear. So you have to know the answer and you have to know the concept behind that, so that you can easily answer in the examination hall. So I think it is today is last question I will be discussing with you. Now, the last question which I am discussing, this is a question of medicine only. Now, question is goes like that. The consider the following. Question is consider the following. One is sulfonylurea, two is bigonide. Bigonide means metformin, and three is thiazolidone. Now, which of the above is or are not recommended for the use of the first line therapy in type 1 diabetes mellitus? Type 1, not type 2. Remember, type 1. So I am repeating the question once again. Consider the following. One is sulfonylurea, two is bigonide, and three thiazolidone. Which of the following is or are not recommended for the use of the first line therapy in T1DM, that is type 1 diabetes mellitus? And option A is 1 only, option B is 1 and 2, C is 2 and 3, and D is 1, 2 and 3. So I think this answer is quite clear, because type 1 diabetes mellitus actually it does not recommended the oral hypoglycemic agent like sulfonylurea, bigonides and thiazolidone. Only because type 1 diabetes mellitus is not a non-insulin dependent, it is insulin dependent. So we actually give insulin and glucose lowering agents with the exception of alpha glucoside inhibitor and amylin analog are ineffective in the type 1 and should not be used for glucose management of severely ill patient. That is very clear. And from the statement it is clear that oral hypoglycemic agent, that is OHA, except those with the lower glucose interfering absorption like alpha glucoside inhibitors, are not useful in type 1. So, okay, so only the useful which we give in T1DM is only insulin. No other oral hypoglycemic agent are used. So this is the last question which I will be discussing, and again I am advising to you all to if any doubt in the UPSC you face in the any question or any doubt you want to ask, you can always ask in our group, which is made by Dr. Rajiv sir, and in my personal in my personal WhatsApp also, and I will try to answer as far as practicable, and I will give the answer with explanation. So this is the actually UPSC paper 1 which I have discussed. Paper 2 already I have discussed. Now after I will be discussing again with paper 1 and paper 2 subsequently, with the more giving stress more on the question which has been coming more frequently, which is being asked in the UPSC exam. So all that for now, and in the next coming couple of days I will be giving discussing the question with you with the UPSC and paper 1, subsequently paper 2 first, then paper 1 again, as just I have discussed just now. Okay, thanks a lot.